Hi, I'm Michelle Ginsberg. I'm Director of Cardiothoracic Imaging at Memorial Sloan Kettering Cancer Center, and I'm also Vice Chair of Education, and I'm a Professor of Radiology at Cornell Medical College in New York. Is radiographic imaging useful in predicting resectability of thymic tumors? Resection is the primary choice of treatment for thymic tumors, and generally assessment as far as resectability is done with a CT scan with intravenous contrast. That is the modality of choice for staging. We know that a complete resection is an important prognostic indicator for patients with this disease and in the predicting overall survival. Therefore, the ability to preoperatively predict which patients are at risk for an incomplete resection could help avoid unnecessary surgery. So therefore, imaging is vital in assessing tumor stage and therefore resectability. So what do we look for on CT imaging? Well, we look for features where we analyze the tumor. So first of all, we look at the size of the lesion, the overall consistency of the lesion or attenuation, and overall morphology. So we look for things like calcifications or maybe necrosis. And the contour, is it lobular? Is it spiculated? And we also look at the relationship of the tumor to the mediastinum. Specifically, is the tumor infiltrating into the mediastinal fat, which would suggest that the tumor capsule has been breached and the tumor extends outside the capsule into the mediastinum. So things we look for are the presence or absence of a fat plane between the tumor and vessels. But that's sometimes difficult because while it may look like there's an absence of the fat plane, at surgery, it may come up that it was just touching it and was actually very resectable. So we also look for the degree of contact to the adjacent structures. Specifically, vessels are very important. The heart, airway, and esophagus, because if those structures are invaded, then resection is not possible. So we can categorize it on the degree of contact with these structures. Is it less than a 10%, or is it 10 to 25%, or greater than 25%? So as the percent increases, it's more likely that it's invading and infiltrating into the adjacent structure, which would make it unresectable. We also look for adjacent pulmonary parenchyma if it's infiltrating, or if there's separate pulmonary nodules, which could indicate metastatic disease. We look for lymphadenopathy and pleural effusions and nodules along the pleura, because that would indicate pleural-based metastases or drop metastases. And certainly, we also look for distant metastases. So two features that we have shown in our studies were significantly associated with an incomplete resection were the degree of the tumor contact with the adjacent vessels and larger size. So the larger the tumor, the more likely that it may not be resectable, and the larger the degree of contact with the adjacent vessels, the more likely that it's not resectable. Now, MRI does not play a major role in the investigation of these anterior mediastinal masses. We generally reserve it for patients that cannot have intravenous contrast for their CT because they may have an iodine allergy or maybe they have renal failure and therefore may benefit from this MRI. But in general, it's a CT with intravenous contrast. That's the modality of choice. What about PET-CT? Well, that may be useful in ascertaining that the lesion is avid on PET and is malignant, but it doesn't really help with actual infiltration and resectability. It does help if it does show us distant metastases, because then you would know that it's not resectable. Dotatate PET-CT is a specific PET-CT that's used in thymic neuroendocrine tumors, and its assessment is useful to identify the neuroendocrine tumors. But again, it may not help with resectability, except in cases where it shows distant disease, which would be considered, let's say, pleural-based disease or metastatic disease that may make this unresectable due to that fact.